So let's move now on to the discussion panel. And if I can invite the speakers to unmute themselves, put on your camera. Let me see if I can move us into a more friendly environment. There we go. Do we have Greg and Russ?
I'm here. You can hear me, Richard?
There we go. We have Russ and Greg. Greg, we can't hear you or see you.
I'm here, Richard. This is Greg.
Okay, can you put your camera on?
Oh yeah, sorry.
Hold on. There we go. He's in a playground somewhere. Wonderful. Okay, let's carry on. So thank you to the audience for posting your questions in the Q&A. Please continue to do so as we have our discussion, which we have labeled longevity, equity, and innovation in AI-enabled health systems. So maybe I can start off. Greg, if you are walking, maybe if you could mute yourself until we ask a question, because there is some background. Thank you so much. So we've heard a very broad range of AI-enabled solutions, primarily around brain health, but also healthy aging. And as Josh mentioned, I think AI is moving us forwards as a planet, as society, and there is much to embrace. As Russ highlighted, it is not going to be detrimental if we harness AI correctly. And we're at the very early stages of the understanding how we can harness and employ AI in our various models. And I think we have many societal issues, not only healthy aging, but of course, mental health that we have touched on. So maybe we can start with the questions in the chat. Just first of all, we had a question, I think that was targeted to Greg, but I think all of us have a view on this. What about individuals who do not wish to have access to digital devices, some of whom may even struggle to interact with via SMS? And I think that's a very important point, because if we're speaking about the older population or those who may not have access to digital technologies due to their current circumstances, it could be a lower income country, it could be the situation as Svetlana presented in Ukraine, where the network infrastructure may be more limited. How would we address that? So maybe I can ask Greg first of all, because you are targeting the older population in care homes.
Yeah, it's a great question, of course, because we do want to provide the best care for everyone, right? Give everyone the best opportunity to live their best life. And so, one of the reasons why we talked about the AI ethical framework and not just supporting and building it for the digital human vision, but to make sure that the about me concept can be facilitated within the human clinician to patient interaction as well. And so a lot of the, as mentioned, the large language models are being tested to support and facilitate, whether it be ambient AI technology or whatnot. By building that, enabling the information that's collected in the HR to help facilitate these human conversations that are focused on about me and always centered on about me, and then being able to evaluate, did we deliver care based off the premises and goals of individuals that resulted from conversation between two humans. And so we want to make sure that's available in that context. But then as well, if someone has the opportunity and wants to and likes to engage with a digital human or SMS at some as well, then that same principles that we build around the or within the AI About Me ethical framework, those are supported there as well. And of course, we'd love to have that used across different settings. So there's always wherever the whatever information patient shares, it travels with them, and they own that data, et cetera. That's another point, but we clearly understand that, and in fact, that's one of the reasons why we started with paper. Paper works. It facilitates about me, but we also know that to scale it, perhaps the quickest way, just maybe that's not right, but at least that's what we've seen across systems and across the globe, because these digital technologies can, look like a variety of people, can speak different languages, and to be able to support as many people as possible. And so again, we clearly understand the limitation, but I will say to the other point is that I think sometimes we underestimate the willingness of older adults to engage in technologies. Clearly, there are limitations technically, or because the environment or social circumstances, but quite a few older adults already use technology quite often. And so we also don't want to make those assumptions and limit the vision, because we might think first that patients or older adults might not want to use the technology, but we should, by trying it out, that's how we'll know and learn.
Great, thank you, Greg. Maybe I can put a slightly different perspective. It may not be the individuals interacting with the digital platform, but the carers and the healthcare professionals and those providing the services for the elderly and other groups who would be benefiting from the AI platforms. So it's not only the end user, and using paper has a different context to using a digital device, as you've quite rightly pointed out. So you're collating all of those paper responses into your AI platform. And I presume that's your training data set from all your paper responses.
We do have that as a training data set, correct, right? We, with 100,000+. And then, as we really try to build out the ethical framework, of course, we'd want to get a broader collection of, data and responses from individuals so that it is diversified, and continue to, as we work with collaborators around the globe, to collect more data, build a broader evidence base, integrate that in, and make sure that truly the principle that we're focused on is making sure that every person gets the care that they need, want, desire, deserve, and so we want to be able to scale that around the world and have more data to validate that what we're doing is right.
Sure. Can I pick up that point? And not only for Greg, but others can come in as well. Collecting data from around the world is immensely challenging, because in the context of health, there's different cultural, ethnic backgrounds, cultural backgrounds, genetic backgrounds, and so on. And how do you handle that in an AI platform? And do you need a very large data set? Do you need to tailor the outcomes to different population groups as well? It's clearly not one size fits all. Anyone want to speak about that?
I can talk a little bit about that. Obviously, when we're trying to build good or very good prediction models, we want big training data sets that are filled with relevant data to the prediction we're trying to make. But the domains are all very narrow and focused. So if I'm trying to predict the likelihood of future workers' compensation claims, or I'm trying to predict the sudden appearance of head injuries in certain locations going up, the likelihood that those head injuries in those locations are going to go up, I'm dealing with a very narrow set of data specific to one employer, right? I may find some relevant head injury data across all employers in the United States, possibly from OSHA, that I'd want to incorporate into that model. But again, that's a very narrow scope, narrow domain problem that I'm dealing with. If we're talking broadly about mental health among the elderly, I still think we're going to have to get very narrow. Are we talking about declining mental health of people with Alzheimer's? Are we talking about people with chronic pain and the impact of the chronic pain on their mental health? And so once we narrow the domain of the problem, I think that narrows the potential data that we want to source to build our AI ML models. And so some of the problem you raised, Richard, is self-narrowing. It just depends on the scope of the problem you're going after, right? And if you want to try to understand, all 20 or 40 ICD-10 mental illness codes across all of the elderly across all of the world, you have a really big problem, right? However, if you're trying to actually understand the impact of alcoholism on people who are over 65 and have been diagnosed as chronically alcoholic, and you're trying to understand that in the Southeast United States, and you're involved with the Health Information Exchange in the Southeast United States that can combine that data for you from, say, several acute care environments and some other specialty provider environments. Now you've got a very narrow domain kind of a problem, and it's less of an issue. So that's my answer on that.
Thank you, Russ.
Hey,
I think
Richard,
that.
do you mind if
Go
I just say
ahead,
something
Greg.
quick?
Go
I think
ahead.
it's real. I think, the response is great. I just want to point out too that what we're entirely focused on is no assumptions. What matters to you? What do you care about? What are your concerns? And I'm going to have a conversation about that right now. And so when you talk about scaling or data, the data we're looking for is that in that moment, and that as a clinician, we are connecting and seeing you as a human and saying, maybe there's 5 things that concern you. Let's talk about, what's the biggest concern? Let's talk about what matters most to you. Let's talk about how we might get there. Let's talk about and then the other things can be addressed. We're not trying to, and I know this wasn't the context, but and that's why I think this can scale, because it's truly in wherever you are, take whatever this About Me card or some other concept. How might you phrase the questions, or might you adjust the questions to your context of how people within your society or your culture or your patient population, what do we need to say to be human and relational? Ask those questions, facilitate it, and direct people to the care that matters. That's it. That's what we're trying to do. And to make sure, what we're talking about the AI ethical framework is that we want to make sure that whether we're doing human-human conversations, digital humans to patients, that is implemented, those concepts that we learn from our societies are implemented in the model, and that we're measuring, are we doing what matters to people? We're not predicting, it's truly delivering care and then evaluating whether or not that care that we deliver matters to every human that we care for. And so we've tested this in Spain and Sweden and in different contexts, in hospitals and primary care and specialty care. And no matter what country we were tested in, the conversations didn't really change, because it's about humans. And it's about what we want as humans. And there's a commonality there that if we can spread and scale and measure, are we doing what matters for humans? There's an opportunity to truly change lives and deliver care that matters, and not any more than that. I'll stop.
Okay, thank you, Greg. Yeah, very interesting points. I guess it's how you ask the questions as to what kind of responses you get as a human. Maybe we can move on to the next question, and that links with a comment that Svetlana had made in your talk about when you're applying for grants that include AI, there needs to be several pages on ethical AI. And the question is, who oversees the governance of your AI models deployment and use? Is there an ethics review board or compliance officer involved? Do you have any comments on that, Svetlana?
Yeah, absolutely. Very good question. So short answer is yes, absolutely, in various forms. Depending on the project, of course, the governance will be different. But if we are talking specifically about EU-funded or EU-supported project, obviously working under that regulation covers all the ethical aspects and being very stringently enforced, there would be a committee that within the project that necessarily would meet and oversee implementation of AI. And we're talking on the technology side, but also what it means in terms of delivery, how it's presented to end users, there's explainability, how it works as part of the overall decision support process. And that will be different for different participants in this story of AI. If we have a clinician, we have absolutely different set of explainability tools and the evidence and the quality and timing. For a patient, another set of ethical constraints would be enabled. So we absolutely do have an internal ethical AI ethics oversight board, there would be an external group that would validate. In the case of EU-funded project like Horizon, there's a specifically selected committee, usually, or at least an expert who would control implementation of the project at all stages, as I mentioned, from proposal selection to the actual implementation, to dissemination of results, and continuation of the project. So it's definitely a thing that would be definitely processes, and of course within large organization that would be a department or a special officer who is responsible for that.
And do you think the this regulatory framework around use and development of AI, so ethical AI, explainable AI, and so on, is that becoming stricter now? Now that more and more understand the beneficial uses of AI, but also perhaps the governance around AI needs to be stricter in not only in health but across many different domains.
I would definitely say it becomes more specific. When we saw the first version of EU AI Act, that was quite a difficult read, basically talking about principle and concept rather than offering exact guidances. Now we have checklists and standards. I saw AI certification pathway. So I think it becomes clearer, but now, of course, more challenges arise with every new release of GPT models and LLMs and new capabilities technology provides. Of course, we're faced with new ethical challenges, how that impacts the society, how it impacts people, as previous question asked, so what if I choose not to be part of this data infrastructure, if I choose not to contribute, but then the sad situation is we cannot really choose anymore. As society develops and uses a lot of AI models, automation, and decision making, we part of that. And when we go to supermarket, our data is analyzed. When we go to doctor, HR would be scanned and used. So we don't really impact. We are part of the system. And the question is, how do we make our voice more clear, more exact, and make sure that AI delivers answers for me, specifically for my group, rather than just someone else. So that's, I think for me, that's a very important question we have to ask ourselves.
Great, thank you, Svetlana. Maybe we can move on to the next question, which seems to be targeted to Russ, but we can all consider it. Are you suggesting that UK startup AI brain health digital solutions would have a faster route to global markets by starting in the US? Where big money is available, and then reverse back to the EU. So you can see that question, Russ. What do you think?
I think the answer is maybe. You know, it's not an absolute yes. It depends on a lot of factors and variables. What your solution is, what types of investors you're targeting. There are less regulatory hurdles clearly in the USA right now. That could change very quickly, or it could change in 3.5 years, for example, based on a different administration coming in 2028, 2029. It could even change within this current administration. It is true that it would be different from state to state within the US. So I'm not gonna try to pretend I have a quick answer to a complicated question. That's a complex question. Every startup faces, or early stage company faces questions like that, and you would have to spend, if you're trying to advise Wynn on this question, which we're kind of, we're taking a quick pot shot at the question here. I would say that's a question that requires a half a day of analysis and study and discussion, sure. And it's a little bit too complicated for me to throw out a seat of the pants answer.
Sure. I mean, asking about global markets and a faster route really depends on, are there reciprocal tariffs to exporting from the US? And that's a contentious issue at the moment. But clearly, there is a different funding stream available in the US, not only through universities, but also the investor landscape in the US. I think it's probably more active than in Europe at the moment. I don't know whether, Josh, you have any views on funding of AI and brain health between the US and Europe. I don't know if you've looked at that landscape, being a part of the funding ecosystem.
Yeah, I would I would say that what is similar in both is that they are quite capitally constrained at the moment. And I don't think that that is a particularly unique thing to brain health, but you know, at the foundation, we haven't necessarily perceived any indicator of more or less success in any one geography outside of receiving significantly more proposals geared towards AI from Europe, which could be a suggestive indicator that in the United States, those needs are being satisfied from elsewhere, not necessitating our funding streams to step in, or it could not. That's a complete hypothesis. It's one that I do hold. Because I think, as you alluded to, the private funding streams in the U.S. do tend to lend themselves more quickly and somewhat more nimbly to allocating capital to some of these things that we're talking about right now. And so I would imagine that in Europe, more capital would be required, but I can't say for certain.
Great, thank you. Let's move on because of time. There's a question, I think, directed to Andre. From Thomas, most AI brain age models show differences at the group level. How is this useful for individuals? Are more detailed biomarkers, so hippocampal volume, better for neurodegenerative disease stratification than a global biomarker like brain age?
Yeah, so that's a great question. The saliency maps that I showed in my talk can be created for individual subjects. And I only showed an example of a group level average across many hundreds and thousands of subjects showing group differences, because that's easy to look at and to analyze and relate to. But the approach we've developed also generates individual maps that allow the user, whether that be a clinician or the participant themselves, to identify patterns of aging that are specific to that person and to relate those patterns to their own trajectory of aging. So that's the beauty of this patient-tailored approach, is that it can create maps for the individual.
That's great, thank you. I don't know if Russ or others have any comments on that, because we're all taking group level data and applying it to individuals in many of these models.
Yeah, so I do have a comment on that. We made a decision on our first ML model, a good one it turned out, to not do that. So I'm not attempting to take an individual worker at a facility XYZ who's had, several triage reports of a particular injury, and then maybe has had some encounters with our providers to help, remediate problems around that injury and predict a claim for that person. We abstracted to a much higher level because it is a very, very big organization. And the organization needs to know things like what are the locations that are probably, based on our prediction model, going to experience increases in severe injuries and increases in workers' compensation claims, such that we can intervene quickly at that location in the next 3 to 6 months and reduce the chances of that actually happening. So they're more concerned in seeing at group levels what the prediction model results are. And there's, it turned out that there's more value in showing predictions around cohorts, to use one of the great terms that Andre used in his presentation, because at the cohort level, when you have prediction results, you can get out ahead of broader, bigger problems. Basically, that's not to say that individual care is unimportant. I think Greg did a great job of taking the potential of this technology down to the encounter between patients and providers and trying to deliver better outcomes for individual patients. That's really, really important. That's the same point I went to at the end of my presentation is as an individual, any individual, you need to think about longevity as a laboratory experiment and collect your data, right? So the individual always matters, but some of these models are better off and of more value when they get to a larger group or cohort with prediction results, because those are more actionable and more impactful, I guess, Richard, would be my summary answer on that.
Great. Well, that's I think the jury's still out, but that's very reasonable when we consider the data we're collecting at group or population level and applying it to individuals. I think it does need to be context specific, and we do need to tailor, the output from our AI models to the context. It's not only geographic location, cultural context, but also the particular use case, what may work in the workplace. And you talked a lot about the maybe health insurance for employees would be very different from perhaps a different mental health case scenario in a clinical setting. So we do need to be aware of the context-specific nature of the real-world outputs in using AI. Let's move on to another question, which relates to participants feeling skeptical about the use of AI. Would you tell, when you're collecting data, questionnaires, and so on, would you tell a participant that it's based on AI or it's going to be fed into AI? Have you encountered that? Anyone skeptical about or worried about using AI?
Well,
I don't want to overtalk. Let somebody else go. Yes, go ahead.
Greg, go ahead.
I was going to say, we, as part of this, for me, you can't claim to build a trustworthy system if you're not, explicit in what the product that you're using or that is supporting every patient. So I would certainly advocate to be open and transparent. But to the point about the digital human part is, so we very much we're building this in collaboration with brilliant minds around the world, and of course those are older adults. And so, for example, we work with a patient involvement group, public and patient involvement group in the UK, part of KCL, and showed a number of people the digital human, a very early version, one that's not already built out, entirely to get their perspective. What matters to you? And what conversation do you want? And as you interact with this, how does it feel? What would you want different? And so, we're certainly building it with them and making sure that we do deliver it in a way that matters to people, because that's why we're building it. And so, certainly for us, transparency and honesty and openness is the foundation. So I would think yes to answer your question, Richard.
Russ, any thoughts on that?
Well, I didn't, I think I just got done explaining that I'm not really down to the individual employee level, but I did very recently have a similar challenge in this area with key decision makers from our largest client. There was a tremendous amount of skepticism about the potential value of the project we've been working on for 2.5 years. And we did get in front of the decision makers, key decision makers, executive level, occupational health and safety people of this client. Again, a Fortune 50 company, one of the largest employers in the United States. And, our COO is really great at focusing me. We work well together. And she said, look, you got to address the so what, And so we wound up with, I would call them insight reports. What does the predictive model mean to you? And one of my 2 data scientists is a good explainer. He's a good communicator. He's a brilliant, physics student. He's a brilliant mathematician. I've combined him with an even more brilliant guy in Kyiv It's a great team. It's a small, great team. And we showed them the predicted hotspots, very simple. And we explained to them very simply why these were predicted hotspots. And they had never seen anything like that. And the other thing that I prefaced that with for these decision makers was the basic value of analytics models. Some of you have probably seen it many, many times. So you're looking at analytics, right? The lowest level of value, it's still valuable, is what happened in the past, right? That's the retrospective view of your data. Then there's the current view. What you're monitoring, what's happening in near real time, what's happening right now. That's a little bit more valuable. The most valuable thing is, of course, what's going to happen in the future, right? And so we showed them for the first time what the model says is going to happen in the future. And we gave them a bunch, and they had never seen anything like that before. And they immediately started digging into other systems and data they had to try to explain some of those future hotspots that we showed them that the model predicted. And so I think, that you have to answer the so what question very directly with people. That may not work as well with the individual, but maybe it will. Greg could talk more about that. The so what, when a provider's dealing with an individual patient, the so what is, we want to give you better care. We want to help you get healthier, right? The so what I'm dealing with an executive of occupational health and safety at a company that employs hundreds of thousands of people is, how are you going to make your program and our program that we're working on together more effective for our employers? So it's the so what. That's my short answer to that. In context, as you
Sure.
mentioned many times, Richard. So
absolutely in context. And I think how we
Yeah.
can reassure our stakeholders, our clients, those who are working with, and it's the insight papers you've mentioned. It's the educating at the appropriate level,
Yep.
depending on the stakeholder, whether it's a C-level executive or person in a supermarket. They need to be reassured in order to engage with the platform, answer the questions, provide the data.
Just to add to that,
Go ahead, Svetlana.
So just building on that, it's not only useful, it would be legally required. So part of the Apora platform, we integrate consent mechanisms, and of course they would depend on the legal regime or, as you say, the type of user we're talking about, from the simple terms and conditions to the next stage. How do we ensure that the user, the patient of the data collection tools actually understands what is being done with the data, how it will be stored, how it will be used in training of the models. And taking it a step forward, the next question is, how do we ensure that any consent I give is actually reliable and not stored somewhere in the big tech silo? So some of the solutions have been proposed around distributed storage of consent and technologies around distributed validation. We have been working on a paper that we will be publishing very soon, covering those methods, and they certainly have a large promise to transfer that power and that control from the systems, from private organizations or institutions or governments back to the user, so they can make informed decisions without the need to study long agreements or being really experienced with technology. So that's the goal.
That's great. Thank you, Svetlana, for highlighting that. We're rapidly running out of time. I know we have one last question in the Q&A. It's about ensuring that synthetic data reflects the diversity and complexity of real-world patient experiences. Are we using synthetic data as a training data set? Is that reliable?
I can comment on that. We have been using synthetic data sets. It has its advantages. It's especially in the context where data is really not available, especially if we're talking about some niche applications of technology. So it's better than nothing. But of course, if we're dealing with highly heterogeneous data sets, that's very hard to model. This limitations to and trade-offs to using synthetic data sets. Although as a technology, of course, it's it's a developing and useful way of augment our distributed and very often limited data sets.
That's great. Thank you very much. And we've just had one very last comment coming in. Before we close, can I suggest forming a focus group following this meeting? Well, we will be emailing you with a link to the video, all of those who are registered. And I'm sure we could have a focus group, a Google group, where we can continue discussion around these subjects, because it's not going to go away. We're going to be embracing it over the next decades and centuries. And this is, as Josh mentioned, how the planet is going to be moving forwards and aging healthily for our own longevity. So let me close here, because we've been going on now for over 2 hours, and it's been a wonderful discussion. We're only just scratching the surface. I've got a long list of other points that I don't have time to cover. So the focus group is a really good idea. Maybe we could have a part 2 of this webinar over the next couple of months. So just leaves me to ask each of you one sentence conclusion. I'd like to give you the final word rather than me. One sentence conclusion about how you think we should be moving on, moving the needle, the planet moving forwards. Start with Josh.
Happy to take it first. I would say direct investment to research. Without doing so, it will be impossible for us to continue innovating and drumming up health solutions that optimize results for absolutely everybody. If you don't know where to find good research, come to us. We're happy to partner you with the teams that we really enjoy working with and have submitted proposals. We're not able to fund everyone also. And so if there are folks that would like to drive investment to some of these sources, happy to do it through us, happy to use us as a proxy, or we're happy to put you in touch with the research teams that we're familiar with. But definitely funding the research, funding other things is helpful and important, but given the current climate and environment where we are right now, it's a necessity.
Excellent. Thank you, Josh, for sharing that. Russ, next.
Yeah, I think I said in my presentation, focus on making healthcare providers better. Make them better at what they do. That's it.
That's great. Greg.
Yeah, it's all wonderful. Thank you. I think about this phrase that I heard a while ago and doing this work is don't do anything for me without me. And I think it centers me a lot on how I think about the tools that we're building and why this about me motto is so important, because if we listen to people, if we ask questions about what matters to them, what they care about, then we'll be able to, as Russ mentioned, optimize the power of clinicians in doing things that matter to people with them and in co-production.
Great. Thank you, Greg. Andre.
I think it's going to be very important going forward, as Josh indicated, to reach out, to collaborate more, and to reach out and explain to the public the value and importance of this research and the impact it has. It's going to have on human lives, and how essential it's going to be to continue to fund it.
That's great. Thank you, Andre. And last but by no means least, my co-organizer, Svetlana.
I will answer with one word: together. Let's continue working on it, co-creating our joint future and joint better health.
That's right. Better healthy brain aging. So with that, let me close by thanking all of our speakers, Andre, Greg, Russ, Josh, Svetlana. This was meant to be UK-US bridge. I think we've got much more US on the call, but I think the audience and the questions were primarily UK. So thank you again to the audience for joining us from wherever in the world you are, and also those who will be watching the recording later on. So with that, I would like to mention again, as I did at the beginning, this webinar is part of the series from Aging Research at King's College London, together with the Centre for Healthy Brain Aging and also the NIHR Health Tech Research Centre in Brain Health. And what we're doing at the research center is to bring together academics and also industry partners into an ecosystem where we can share best practice and also funding opportunities. So if you go to the event website, there's a link there. Please do have a look at it. And of course, the final thing to do is to thank the Longevity Science Foundation, our supporter over many webinars over the past 3 or 4 years. Thank you, Josh, for joining us. And think about how you can contribute to the longevity ecosystem, moving the needle on longevity research, healthy brain aging. It doesn't only have to be philanthropy, but just by engaging with the LSF, I think we can all make a difference because of the dissemination of information. So thank you again for all of you joining us. With that, I will close the session. It's been a wonderful time. I wish we had another 2 hours.
Thank you.
Thank you all.
Thank you.